So I'm Dan Bauer, I'm professor of anthropology, and I also teach in global studies. And so we've been doing this Global Salon Series for about 9 years now, maybe even 10 years, trying to put together 3 or 4 speakers a semester dealing with any variety of topics that has some global orientation. And one of the first people to respond to my call this semester for presenters was Dr. Jeri Berger. And so we're very thankful to have her presenting today on health and healthcare in Kenya. She has a PhD in nursing from St. Louis University and has been teaching nursing for over 30 years, including 18 years here at USI. She's done multiple study abroad programs to England and Germany and mentored students in those programs. And so she has a wealth of experience and background. And she's also developed a course with Dr. Kevin Valadares on global health, and she teaches that course as well. And so we're very happy to have you here today, Dr. Berger, and we're looking forward to learning a little bit about health and healthcare in Kenya.
My presentation is going to focus on health and healthcare in Kenya. Just a little background. In March, the first 2 weeks of March, my husband and I traveled to Kenya, and he has been working with a couple different organizations and had some projects going on. So he was working with the Youth Cafe that has programs to empower youth, and then also locally, the Aldersgate United Methodist Church has an ongoing mission over in Kenya in Ekerino, which is out in the rural areas. And I am the beneficiary of these projects because I was able to go along and have a lot of interaction, meet a lot of people, and see a lot of things firsthand. And I also want to give a shout out of thanks to Lynn Rennie at Aldersgate, because she was able to connect me so I could actually meet both nursing students, healthcare providers, and see some healthcare settings. So just a map to show of where we were at. We were primarily in Southwest Kenya, kind of central and Southwest. So we were in Nairobi and then out into the rural area of Kisii, and Ekerino's up here, Myra, and I'm going to apologize right now for my pronunciations. I know they're not right. It's where I saw a county hospital. And then my husband and I did spend 2 days and 2 nights at a camp with a one-day safari down in the Mara area. Kenya is just a very diverse country. It has the modern urban areas. This is Nairobi. It has the smaller towns, small cities, the very rural area of the Rift Valley. And it is made up of many ethnic and tribal groups. I saw one figure that said there's about 42 different tribes in Kenya. And you can see on the map here just a lot of different ethnic groups and tribal groups, which adds to the complexity and the diversity in the country as these are merging together and coming together as a whole with some very different cultural traditions and languages. So I'm going to focus mostly on health, and trust me, this is nothing that's going to only apply for people who are healthcare providers. And it's not a full picture of the health and healthcare in Kenya, but it's information that I gleaned and things that I saw while I was there, and then a little bit of research and things before and after the trip. So as you can see, life expectancy and child mortality have improved dramatically since 1990 in Kenya. But in spite of that, the 4 of the top 5 leading causes of death are infectious diseases. As opposed to here where it's the chronic diseases, the ischemic heart disease, cancer, stroke, and those sorts of things. Those are starting to become more prominent now in Kenya as people live longer, but the infectious diseases are still a really significant problem. And so I'm looking at health through the framework of social determinants that affect health. So I kind of use that framework to help organize some of this. So remember back, we said that diarrheal diseases were a major cause of disease. So starting with safe water and sanitation, 40% have unimproved water systems and 70% lack access to sanitary systems. And that really varies depending on where you're located. You know, in modern buildings in Kenya, it's not, or in Nairobi, it's not a problem. But out in the rural areas, there's much less access. Everybody drinks bottled water. Now, I'm sure if I was further out into rural areas, I was pretty rural, but even further out, or in homes out in the very rural areas, or in the poor areas, they may not have access to the bottled water. But where we were at, it wasn't just like they bought bottled water for us as tourists. They they drank it themselves as well. So the bottled water was everywhere. There was piped water, I think pretty much everywhere we were at, but you couldn't drink the water. It was safe though in terms of showering and that kind of stuff. I had my first experience with a squat toilet. Those of you who've traveled probably have already had that experience, but for me, that was my first. And this one that's in the picture is very clean, relatively clean. I had one that was interesting. There was no lighting, but it didn't really matter because there was so much room between the boards that the sunlight came in anyway. It was fine, you know. And I had to put my picture of the shower with the electrical wires because, especially not so much in Nairobi, we didn't have this, but other places, that heats the water, and you turn it on and it heats the water, and it always kind of makes me a little nervous that I'm showering where there's electric wires kind of hanging there. So, but we didn't get electrocuted, so all is well. Also with sanitation, we're constantly hearing right now about hand washing, right? They already got this down. It took me 3 days to realize what I was seeing. Every place where there was food, every restaurant, dining area, there was a sink for washing hands. The bottom right, the second day we were there, they took us to this place called Bomas, which they have all these kind of replicas of all the different tribal groups in their housing. It was a fun place. And we ate lunch there. This was the hand washing station. I didn't realize that's what I was seeing at first. We had our wipes with us and the hand sanitizer and all that kind of stuff, you know, but this was their hand washing station. The top one here is a restaurant that we ate in Narok as we were traveling. And it's almost like a stall, you know, with all these sinks here. So in restaurants, we always would see these, and people used them. I mean, they weren't just sitting there. You'd see people sit down, start to order, and then go over and wash their hands. Dining areas, this was at Equirino where we stayed, and there was a sink in the corner. And this was actually the camp that we stayed at out at the Mara. And you can tell it's a tented area, but there's a sink here, and there's towel and soap. And it was an expectation that you were going to wash your hands. They would say, there's the sink, and, you know, and people would come in and wash their hands before they ate, and after they ate many times as well. Also, some other things that I noticed in terms of kind of health promotion and disease prevention, and one is the diet. Every meal that we had where somebody was serving us. So, I mean, we got served at the camp, we got served at Equirino, we ate in homes 2 different times. We stayed in a bed and breakfast in Nairobi, so we had breakfast there. The dessert was always fruit. There was fruit with every meal. There was, with the other meals, there's always lots of vegetables. You will see, this is my plate from out at the Bomas where we ate lunch. And yes, I did have to take a picture of this because it's the fish with the head and the whole bit, but that's called wet fish because it's got the peppers and onions and things on it. It's moist. But the greens, and the greens were very common. We had them constantly, and other vegetables as well. And I'm told that a lot of people have small gardens and they grow the greens. So even people who have very limited resource frequently have vegetables. They grow the vegetables, or they can buy them very inexpensively. And so many of the meals were some meat and lots of vegetables, and then fruit for dessert. Might be served with ngala, and also that's the cornmeal maize type of dish there, or chapati, which is almost like a naan bread. And they have various kinds of meats, and you can see on the left, that's the restaurant. They like chop up the meat and just grill it. It's got bone in it, it's got gristle in it. The meat is tough, it's gristly, and it's absolutely delicious. It was wonderful. But they have goat and beef, and I think we had pork, and I know we had chicken. But you know, these cows aren't sitting around in a feedlot. They're out on the grass being moved from one place to another, so they're more muscly and gristly. Also, in terms of disease prevention, I have a picture of the bed netting. That ended up being kind of interesting because we had to request to have bed netting in our room in Nairobi. And we were told, well, you know, we really don't use it very much, only if it really becomes a problem. And Nairobi is pretty low risk for malaria, but you know, me being a nurse and being rather paranoid about malaria, I wanted the bed netting. So they got it. We arranged that ahead of time. We were going to stay, we were looking at where we could stay in Kisii, and there was this one hotel that was highly recommended, had did conferences and things. And I kept looking at the picture saying, there's no bed netting. And maybe it's just a picture. So we called them. They said, no, we spray the room before you come. And then we put a little like mosquito light in there. And I'm thinking, nah, I don't think so. So we stayed, at Dan's Hotel, which had bed nets on every bed, but the bed net was installed in a way that it really wouldn't stay on the bed. So, you know, you'd wake up 3 times during the night with big gaps in the bed netting. I think there's some health literacy issues here because the owner of the bed and breakfast where we stayed, it was the day we were heading out in the country because we were there for 3 nights, 2 nights, 3 nights, whatever. And then we were gone for a week and then we were back there. And so she had come in that morning and she's like, yeah, you know, I really don't know what causes malaria. You know, I travel out to such and such a place and I get malaria, but I never seem to get mosquito bites. So I don't really think it's from the mosquitoes. I don't know what causes it. And I'm thinking, this is a well-educated woman. She's a business owner, you know. So they do make more and more effort to help prevent malaria in pregnant women. And I did see signs up regarding that, where they could get bed nets and where they could get the medication to help prevent malaria. And some people take it a little more seriously. Angela, you'll see pictures of Angela, is one of the young women my husband is working with, said if they travel to such and such a place, they would take malaria meds because it was so much of a problem in that area. Also looking at infrastructure. When I think of infrastructure, I think of the water systems and the sewer systems, which I've already addressed, but also the housing, the roads, that side kind of infrastructure. And you can see Nairobi has some very modern highways. They look sort of like ours. As you get more rural, the roads are not as good. The roads are not as well maintained and things. And in terms of housing, you have high rises, you have apartment buildings, and then you have more, the bottom left picture was in Kisii, and this was out of a view from where we were staying. And you can see the buildings are wooden buildings, and they're in okay shape. The one on the right here, this is Kibera. Kibera is one of the major slums. There's Kibera and Eastleigh, which are both really major slums in Nairobi. I've read that Kibera is either the biggest or one of the biggest slums in Africa. Kind of depends on who you talk to and how they figure that number. I was not expecting to actually see it, but we were in an Uber and there was some blockage in the road, so we took a different road and we drove right through the middle of Kibera. I'm sitting in the backseat going, we're in Kibera, yeah. But we were on the streets, not out in the little alleyways, which would have been very interesting, but even on the street, you could see a lot, and you could see down the hill once in a while and just see a sea of the tin roofs. And these are the structures. And that area would not have piped water, would not have a sewer system, or at least limited. I have seen the pictures of the water stations where people come and get the water and take it back home with them. And yet, many people who live in Kibera are coming out into the city and working in stores in various places. So it's an interesting part of the city. Eastleigh can be much more dangerous. I didn't get close to Eastleigh and I don't want to, but we did get to see this area. And when you were up high looking at the city, you can see all these buildings and then you see an area that just looks like it's blank. It's like there's trees and stuff there, and that's the slum area. That's the Kibera area. Accommodations, which also kind of reflect the infrastructure. These are the places that we stayed. This is where we stayed in Nairobi. And it's a modern apartment building, and that's what it was. It was an apartment building. It was not a hotel. It had gate. It had 24/7 security. This was the hotel up in Kisii. This is the camp we stayed at out at the Mara. And this is Ekureno, and they built on this top part. This bottom part is now the health center. And the top part has housing. So when medical teams come in, they can stay there. And then in contrast, as we were driving around, I saw a lot of buildings that were labeled as hotels or boarding or whatever. This one says boarding and lodge on it, and this one actually says hotel on it. You can't see it very well, but lots of these little buildings scattered around in the rural areas. So the infrastructure and the impact that has on health really varies depending on where you're living and the resources that you have available to you. And then traffic. I can just say traffic. In the cities, it's heavily trafficked roads with a mixture of people walking and buses and everything. You will see here, this man here, if you stop at a stoplight, they come up and try to sell things to the car, in between all the cars. In the rural areas, you may have a different kind of traffic jam, cows or goats. This felt pretty normal to me because I'm from a rural area. So I mean, not that I see this, but it didn't surprise me as much, but the traffic is quite interesting. There are very few stoplights, even in Nairobi. And so when you're walking and you need to cross the street, you're just dodging traffic to cross the street. The side streets can also be very busy with you kind of walking along the side of the streets as people are whizzing past you. I've got a little video here. I don't know that this is going to play. Oh, there it goes. Okay. There we go. This is from inside the car in Kisii. So this is not a huge city, but you can see how it's a mixture of the cars and the matatus, which are vans, the public transportation, buses, trucks, boda-bodas, and that's the motorcycles. The boda-bodas are the motorcycles, and they carry people, they carry cargo and things. That is one cultural experience I did not take part in. I did not ride a boda-boda. I kind of wanted to come back. And then the pedestrians, and they're all sharing the same space. And they do drive on the left-hand side of the street. It was originally, had British colony there, but they only sort of drive on the left-hand side of the street. And traffic laws only sort of apply. My favorite was as we were leaving Nairobi, there was an area where they were building a new lane, a couple lanes or something, and it was graded. It wasn't paved yet, I don't think, but it wasn't open yet. And our driver, Juma, just pulled over there and started driving on it. And it's like, really? Yeah. And he's like, well, they're not working on it today, so we'll just drive on it. And the other was, you know, when traffic gets backed up on the highway, they just pull over on the shoulder and start driving on the shoulder, which isn't so bad, except when the shoulder starts to go away and the gap between the shoulder and the highway gets even more. So the traffic. And then that leads to, why is this an issue with health? The road traffic deaths. United States has 10.6 per 100,000 and Kenya has 29.1. So almost 3 times as much in terms of road traffic deaths, but not as bad as Thailand. I think India is probably right up there as well. And then I found this one graph, and it's data from 2013. So, you know, it may have changed some, but I think the percentages probably are still similar. 47% of the deaths are for pedestrians. And I don't think that's real surprising when you see what's going on there. You know, you survive a traffic accident better if you're in a car than if you're walking. Okay. And then the gig economy, I'm going to skip that and go right straight to this. When I think of economic stability and the effect that has, I don't know a lot about the economic stability in Kenya. I kind of heard various things like it's not as good as it was. It's certainly better than it was, you know, 20 years ago. But one thing I did learn is it's very much a gig economy. 17% are formally employed. And that doesn't mean that people aren't working and making any money, but in terms of a job that has benefits and all that kind of stuff, 17% are formally employed. Some of the gig workers, the street vendors and stalls along pretty much any street, you saw the little stalls where they were selling everything from bottled water to fresh fruit to vegetables to clothing to tools, whatever. Big markets that were not, I've seen markets for like the tourism types of stuff and that sort of thing, but these were markets that sold the clothing and the food and things that people are using. And we saw one as we were driving out of Nairobi, and Juma told me, he says, well, a lot of people come here and do major shopping because it's so much cheaper than like department stores or anything. And my understanding is they get in like big things of used clothing. And so people go there to get their clothing and things. Drivers, people who have resources and have a car have private drivers. A lot of times, twice I rode with somebody with their driver in their car. Taxi drivers, Ubers. By the way, the Uber app from us works exactly the same in Kenya, and it's amazing. The Uber was great. Security personnel, there is security in Nairobi everywhere. Any kind of shopping area, mall, small mall, they had a metal detector when you came in, and security people there looking in your bag as you walked into the shopping area. Hotels or apartment buildings and things have security. The one we had in, like I said, it was gated, and there was 24/7 security there. And then the domestic workers. Lydia worked at our bed and breakfast. She cooked us breakfast every morning. She spoke English, sort of. She spoke English some, and enough to communicate the basic things. She helped me do laundry one day. There are a lot of domestic workers. A lot of people will hire somebody to work in the home. And then the other thing that was just really interesting was a money system called M-Pesa. M-Pesa is mobile money transactions, and it is through Safaricom, which is the major cell phone company, internet company. And it's sort of like they skipped the whole desktop PC era and have gone straight to the smartphones and all of those mobile resources. But M-Pesa, you take money and you go to a Safaricom shop and put the money into your account, and then you use your smartphone to pay for everything. And it's very equalizing. People don't have to have enough money to open bank accounts. They don't have to fill out all the paperwork associated with a checking account or savings account or whatever to get a loan and everything like this. Everything is done through M-Pesa. And so even in Kibera, this middle picture here, M-Pesa eggs and gas. So they can buy their eggs and their gas there using M-Pesa. So even if they only have $50, equivalent of $50, they can put it in M-Pesa and use it for all their shopping. We did have a Safaricom phone, and if I ever went back, if they would let me, I'd open an M-Pesa account because it was the easiest way to pay for everything. As we were driving down the road in the middle of kind of nowhere in Kenya, Juma needed to pay his water bill. Angela got on her phone, used his account, paid it, transferred money from his account to her, and they were done in like 5 minutes paying his water bill. And we might do that, but it'd be through a bank. And whereas this is not through a bank, so it makes it more accessible to a wider number of people. We saw it rural area as well as in the city. Education. We all know that education really has an effect on health and health status. The literacy rates have definitely increased, and education has increased because you can see that the younger age has a much higher literacy rate than the older people. They do have compulsory education, ages 5 to 17, although I would not certainly guarantee that everybody ages 5 to 17 are in school. There's definitely a difference between urban and rural and public and private, with the rural schools just don't have the same kind of resources. And the children in the rural areas may not have electricity. They may not have the resources then of what they can do with that. Many people who can send their children to private schools, the young people we interacted with had all gone to private schools. But the public school is available. And again, it may be a distance away, and that's the other challenges. They may have trouble getting there as well. In terms of gender equity, I don't have any statistics on gender equity. I just know that we met several young women in Nairobi who have high education, college level education, and it did not seem to be a lot of difference there. However, in rural areas and certainly in some of the tribal areas, because of their culture, there is still a significant difference. There are still ethnic groups that encourage the young marriage of girls. and the girls not having much education. And in some cases, the boys not going very far in education as well. So there is still some problems with gender equity. We did visit a Maasai school. The camp that we stayed at was a very interesting place because it had been developed. A group of Maasai villages went together and purchased this land and developed this camp because they said they saw these outside companies coming in and doing this. They developed this camp. They've slowly built it up. I think there's 5 or 6 units there now. And the proceeds from that camp go back then into the community. And one of them is this school that they have opened. They have, I believe it was preschool through 6th, and they were building the building to go on up through 8th. And I think I've got that right. The younger children up in the upper right sang us a song. I'm sure it was in Ma, which is the Maasai language. It might have been Swahili. The older children were learning in English. And this school, it can also provide boarding, so the kids can stay there. Some of them stay there during the week because it's too far for them to go back and forth every day. It'd be too long of a walk. Others stay there, and the statement was because if they go home, they may not be allowed to come back to school. And this was especially for young girls after they reach a certain age. And what I found interesting was this is not an outside group coming in and saying, this is how you should do it. No, this is within their ethnic group saying, we need to make these changes and we need to support and provide the education and make sure our children are educated so they can be successful in the world that we live in. I just found that interesting. It was internal rather than white people from the outside coming in to make these changes. People in Kenya frequently speak 3 languages. Swahili and English are both official languages in Kenya. Angela said, you learn Swahili in Nairobi, you learn Swahili at home, you learn English when you start school, and then you learn your tribal language when you go to visit grandma out in the country. And I thought, well, that's kind of cool. But then if you're in the rural areas, you're probably going to learn your ethnic or tribal language first, and then start learning English and Swahili once you're in school. Most people we met, we heard a lot of Swahili, but most people we met spoke English just fine. Occasionally not so much. I had a very interesting unplanned taxi ride with a large Kenyan man who did not speak English, or at least I couldn't understand him and he couldn't understand me. And we went through a major thunderstorm with hail. So that was one of those interesting unplanned adventures. Yeah. Social support is another aspect for health, and we really sensed that a lot while we were there. The picture in the upper left, this is actually looking over the Rift Valley. And Angela's on the left and Rahema's on the right. And I still keep in contact with them. I would consider them friends. And they took me shopping my last day we were there. And then on the right, you see the Maasai men. They are not dressed for a performance or something. This is where they live. This is what they're doing. It's a very communal society. And I sensed it, but they also explained that to us. We'd be going in to eat, and all of a sudden there's other people coming around. And it's like, okay, where'd they come from, you know? And they just come and gather because that's what they do. And they help each other out. We ran across a couple vehicles got stuck when we were out on the safari, and they stopped and made sure everybody got pulled out okay. And as we were driving, you'd see groups of people kind of gathered together, sitting around and things. Some of it is because of the employment problem, that there's not jobs. Some of these men are probably waiting to see if somebody comes and needs a day laborer or something like this. But there's also just a community sense there. They don't necessarily isolate in their homes. And then just a little bit about the environment. Kenya struggles with both droughts and floods. They have the cyclic type of thing. And that really affects the food production and the food availability. And then you have the densely populated areas that have a lot of problems with air pollution. With all the trucks and the cars, and they're not in good shape, so emissions are not good in your rural areas. However, in spite of everything, all their challenges and stuff in Kenya, they are very environmentally conscious. They have banned plastic bags. About a week before we left to go over there, I saw a news article that somebody gotten arrested because they were selling plastic bags, apples in plastic bags along the roadside. After we came back, they announced that they were banning one-time use plastic bottles, which I'm thinking, I don't know how many we went through because we were drinking the bottled water all the time. You know, and reflecting back, I think, you know, they're very connected in many ways to the land. even the people in Nairobi, most of them have family that are rural areas, or they came from rural areas in there. And the country has so much beauty. The top right is the tea fields, and that's up in the Equirino area, the savannas. The bottom left are the Maasai moving their cattle around, and just the beauty of the land and the amazing animals. I couldn't do this presentation without putting in pictures of amazing animals. We did have a one-day safari, and it was amazing because just the two of us with two guides. And my husband was quite relieved when we saw the giraffe, because I had said I was not leaving Kenya until I saw giraffes and zebras in the wild. So I'd already seen zebras, so that was a good thing. But there's more than this, but you know, these are just wonderful. And then looking just a little bit at healthcare itself. Healthcare is accessible. I mean, people have access. Everybody is covered. They can access, but being able to access is different. They may not be able to get to places because they're too far away, that the quality of the healthcare that's available in their area may just be somewhat limited. I'm going to go through this very quickly because this is not about the healthcare per se, but they have different levels of healthcare. And so the first two levels are more the clinics, not really clinics, but offices more. They provide some education, they provide some basic laboratory services, basic pharmacy services and things. You do notice though, there's a lot of things about health education with maternal child. And I think that's part of that big push to try to improve that maternal child survival. We did see clinics and things as we drove around, the St. Anne's Medical Clinic. I think this would be a level 2 clinic, and the chemist has the prescription drugs, the medications. And then you also saw a lot of like natural herbal medicines and things, fit and fine health therapists. This was, by the way, like in the same building as this, just down the road. And then we had level 3 and level 4, which are more clinics and small hospitals. Every county has a hospital. And so there's a level 4 county hospital. Now, I visited a level 4 county hospital, and this description does not fit it. It was much higher level of care than what that description is. After I got back and I started looking, I found out that this particular county hospital has some of the best outcomes in Kenya. So I think I was seeing kind of a skewed picture of what the county hospitals might look like. But this was a maternity unit. And again, they're a more communal society. These are curtains. They could have them down between the beds, but they don't. This is the labor and delivery room, by the way, and this is the delivery table. There was nobody in there, so I felt a fear to take some pictures there. The ophthalmology services is interesting because this would normally not be available except in major cities, but the mission at Equirino with the Amani Center has worked with them and donated equipment and has done training, so they can now diagnose and treat cataracts. They can do cataract surgery at this hospital out in this very rural area. So that's pretty cool. And this is Dennis. And they were very kind to me and showed me all around, introduced me to all sorts of people at the hospital. And then you have your level 5 hospital, which is kind of like we would probably have here, that same level of care. And then level 6 are the national referral hospitals. There are 3 that serve Kenya and East Africa. One is in Northwest Kenya, one is a psychiatric hospital in Nairobi, and then there's Kenyatta National Hospital in Nairobi. And this is the public hospital. There are also private hospitals. So people who have money may choose to go to the private hospitals. The environment is going to be nicer, but they have all of the specialized services, and there are some things that this is where you would need to go to be able to get that level of diagnosis or care. They are affiliated with the University of Nairobi, and I did go to University of Nairobi and met nursing faculty and the dean. And my thanks to Dr. Irene Megero, who has been here in Evansville for 3 years. And then that's who I was able to connect with and meet them. And I spoke with a group of nursing students and faculty, which was pretty much just like talking to nursing students here. They wanted to know how they could come to the US to work and why US students didn't come there and have experiences with them. I asked how big the hospital was, and they told me 1,800 beds, but they said, but we're a public hospital, so we can never say we're full. That was the statement. So if we need, we just add extra space. We add mattresses or cots on the floor. I never got to an adult ward. I think it would have been interesting. It was visiting time and it wasn't a good time to try to go there. I did get to a labor and delivery room and did see at times 2 women sharing a bed. So it's crowded, long wait times and things, but they do provide high-level services. Also, as part of Kenyatta National Hospital, there's a whole building that's designated, nice building for HIV/AIDS, and also a pediatric oncology center. So this is a major medical center. Nursing in Kenya, I have to mention that since I'm a nurse, but there's 3 levels: enrolled, diploma, and BSN. Enrolled is sort of like our LPN, and then the diploma and the BSN. And if they practice for 3 years, they can get a private practice license where they can run a clinic or a nursing home. There's also specialty areas, and they do additional education to practice in specialty areas. Out in Emira, I met 3 nurses in a dialysis unit. Like I said, this was a much higher level, I think, hospital than many of the county hospitals. Dialysis unit looked not a whole lot different than one might look here. But they told me that they had their diplomas and they had practiced, and then they had 1 full year of additional education and to become the renal specialists. And they were wonderful. I probably sit down and visited with them for 15, 20 minutes in their unit. They were great to meet and see. One of the problems with nursing in Kenya is nursing in the US is very respected profession. It's not in Kenya. It's not necessarily a respected profession, and they have trouble getting jobs. Even though the healthcare is so needed and there's such a shortage of it, they don't hire. And so they have trouble getting jobs once they get through school. And they're not necessarily viewed as positive as what we would be used to. So just kind of in summary, whenever you travel, if you can and you can get that interaction and not just, go tour things as a tourist, you get those cultural experiences. And to me, the world becomes smaller and it becomes friendlier. So I just want to give shout out to planned and unplanned adventures. Those are always good, and they add to the experience. New friends, and I truly mean that. This is Angela's little brother, and we had taken a box of chocolates over there. This was his reaction to a box of chocolates. He was pretty impressed. And we had dinner with her and her family. This is again up at the camp. And this is up in Ekureno, one of the women we met at Ekureno, Rahema and Angela, and James the chef. Very important because James taught me how to make mixed tea, which is this amazing tea that has ginger in it, and we brought it home with us. Dennis, a nursing student at Cassie that I met, and last but not least, Savannah. Savannah was the dog at the camp, and you might be able to see, she actually had a beaded collar. And the beadwork is very Maasai. You might see I have my Maasai earrings on today with her name beaded into the collar.
We started to talk about it a little at the end, but your trip was in March of this year.
Yes, yes it was.
So how was that coming back to the U.S. during the pandemic?
It was an interesting time. They had the first confirmed case of COVID-19 the day we left Kenya. And, being the nurse, I did pay attention. I was paying attention to what was going on over there, watching what was happening. And it was an interesting time to be there because one of the things was they were starting to make plans. They were screening. We were actually screened more. Now, it was kind of limited, but screened more coming into Kenya than we were when we came back to the US, honestly. So they had been doing screening. There was real concern there that they had flights coming in from China. There's a fair number of people that are Chinese who live there in businesses that are Chinese, in Nairobi especially, and Mombasa, I think. So they were concerned that they were bringing it in. So they had established a quarantine unit, a 100-bed quarantine unit in Mombasa. They talked about that. I saw pictures of that unit. They talked about doing screening at Homa Bay, and I'm like, what's a Homa Bay? Homa Bay is a port on Lake Victoria. And what I learned is the fishermen from all the countries that all around Lake Victoria, that's where they come into Kenya. So they've learned, because of their experience with Ebola and other infectious diseases, to how to screen. And so they were screening at Homa Bay, and the hospital where I visited out in the country was the designated place they would take people if they needed to treat them. That was announced just a few days after I had been there. Looking at the US from over there was also interesting because you could kind of see all the chaos and everything, but we were outside of it. And so we arrived back on the 14th of March and right into the middle of it. So it was like, did not realize quite how chaotic it had become and things. Again, that looking from the outside, looking in. So that was interesting.
From Carissa in the chat, and she was wondering how this trip may have changed your overall view of healthcare, if at all.
I don't know that it changed my overall view of healthcare. I've studied about healthcare in other places. I think I just developed a better understanding of what it's like there and how, the structure, it may feel very foreign. The thought of being sick and going to the hospital in Kenyatta was really rather overwhelming. However, they can really treat a lot of things. It's not that the care is so bad, but the environment would be very foreign to us. I'd actually feel much more comfortable out at the county hospital. That one didn't feel real overwhelming to me, but the Kenyatta, that pretty much did feel really overwhelming. But there's also the private hospitals there as well. I did definitely get that understanding that the richer people have a lot more choices. They have a lot more options of where they want to get care, how they get care. And whereas the people with less resources, it's available, but again, they don't have as much control over what it might be and how they would access it.
There's another question I received. What can the U.S. learn from Kenya's health practices and Kenyan society in general? Oh,
goodness. That's a good question. Well, I think in terms of Kenya, health practices, they know much more about controlling infectious diseases, really, than we do. There was not this, what do we do? What do we do? There's a pandemic coming. What do we do? They knew what to do. And they said that, hey, we've been through this. We kept Ebola out of the country. We've dealt with cholera epidemics. They still have outbreaks of cholera. So, they know more about how to deal with infectious diseases, I think, than we do in many ways. What else can we learn? And I think some of the things about the social support, perhaps, I don't know. Yeah, that's a good question. I'm not sure.
I'll have to think more on that one.
I have to think more on that. Yeah.
We've got another question in here from Heather. She said she may have missed it, and I think you did touch on it at the beginning, but why did you choose to travel to Kenya? Was it for the healthcare aspects or just to travel?
My husband had been working with Willis. Willis is the executive director for the Youth Cafe, which is really an interesting organization and they now have major international grants and things to do programming. But he'd been working with him for, 3 years or so, doing some consulting to help him with like grant writing and some just ideas and stuff. Willis just found him, and we don't quite know how he found him, but he found him and reached out. And so they'd done things through Skype and stuff, and they had, he came twice to the US for things, once for a month-long leadership conference and once for just a conference. And we were able to travel and meet him. We saw him over in Kansas and we saw him up in Dayton, Ohio. And then he said, it's time for you guys to come over and see us in Kenya. And so it was like, yeah, twist my arm, let's do this. And then was also able to connect with the people at Aldersgate and get those things arranged. So since we were going, I made a real effort to try to connect with healthcare and nursing and things, but it was, that's why how it got started and how we ended up going there.
Okay, thank you very much, Dr. Berger. We appreciate that. It was a wonderful presentation, interesting topics that you covered. And I just want to mention very briefly, our next presentation will be 2 weeks from today on the 29th of October from 3 p.m. to 4 p.m. And Dr. Jenna Klusterman is going to be presenting. She's an assistant professor in engineering, and Life and Science at McMurdo Station in Antarctica. So thank you again, everybody, for showing up. We appreciate it. And thank you, Dr. Berger.